Okay, good afternoon, my dear friends. It's time. So, today we'll talk about clinical presentation of diabetes mellitus. Clinical presentation of diabetes mellitus. So, discussed already that we have two types of diabetes, type 1, type 2, and clinical presentation depends on type of diabetes. Of course, we have some signs which are common for all types of diabetes, but nevertheless, presentation of diabetes depends on type of diabetes. So first type of diabetes usually presented acutely. So we have acute presentation of the disease. So young people, and you know that diabetes type 1, this is diabetes of young people, and young people often present a 2 to 6 weeks history and report the classic triad of symptoms. What is about triad of symptoms? This is polyuria, this is thirst, and weight loss. Polyuria, polydipsia, feeling thirsty, and weight loss. So, if we talk about these three signs: polyuria, polydipsia, and feeling thirsty. Polyuria, this is evacuation more than 2 liters of urine per day. The polydipsia is consumption of more than 2 liters of water per day. Feeling thirsty, no, this is why patients drink water. Yeah? How we can explain these actually signs? How we can explain these signs? So number one, this is polyuria. Polyuria, due to the osmotic diuresis that results when blood glucose levels exceed the renal threshold. Remember, when we discussed glucose exchange, I told you that in kidneys, when we have primary urine, this is plasma of blood, and small molecules of glucose easily pass through glomerular filter. And concentration of glucose in primary urine in kidneys, the same as in blood. But in tubular system, we have reabsorption of glucose because the organism never lose so good thing as glucose. That's why normally all glucose reabsorbed, and in urine we don't have glucose. In urine of healthy person, you never find glucose. But you should understand that this reabsorption, this is active process. It means that some enzyme, some protein should catch glucose molecule from urine and send back to the blood. It means that we have some system. This system has some limits. And as normally glucose level of healthy person never exceed 10 millimoles per liter of glucose, this system works proper way when actually glucose level less than 10 millimoles per liter. But in patients with diabetes, glucose levels may be much higher than 10 millimoles per liter. For example, it may be 20 millimoles per liter. And what happened then? In primary urine, we have also 20 millimoles per liter of glucose, and this reabsorption system can send back to the blood only 10 millimoles per liter of glucose. It means that the rest of glucose, 10 millimoles, 20 minus 10 equals 10, will be excreted with urine. And in this case, we'll find glucosuria, so presence of glucose in urine. But these small molecules, when they travel in tubular system in kidneys, they start working as osmotic diuretics. Remember Osmo's law. Osmo's law. If we have semi-permeable membrane, and from one side of this semi-permeable membrane we have pure water, and on the opposite side we have some solution, for example, a solution of glucose. What will be direction of water flow through semi-permeable membrane. Direction of water flow will be from pure water to the solution of glucose. This is Osmos law. The same happens in tubulus. If we have high concentration of glucose in tubulus, water try to return to tubulus. Tubulus we need to concentrate urine again, to reabsorb water. But in this case, glucose molecules don't do it due to Osmos law. As a result, we have polyuria. Now we have polyuria. Patient with diabetes with glucosuria excrete more than 2 liters of urine per day, maybe 3, 4, 5 liters sometimes. And this is first sign polyuria. Now, of course, if the patient lose water, to maintain water electrolyte balance, what then happens? Patients start feeling thirsty due to resulting loss of fluid and electrolytes with urine, and then he starts drinking water, and that's why we talk about polydipsia. Polydipsia. Patient with diabetes also, to compensate this water loss, may drink 3, 4, 5 liters of water per day. You know, clinically, you may even ask your patients. Normally, for example, we never drink water at night, for example, and usually we don't urinate at night. Patient with diabetes usually urinate a few times per night. At the same time, she goes to drink water a few times per night. Sometimes he even puts some bottle with water near his bed and drink water during his night. So again, patients with diabetes, they can't live without water. They lose water, they should compensate this loss of water. And that's why we have again polyuria, feeling thirsty, and polydipsia. All this due to actually polyuria caused by extra amount of glucose in blood and due to glucosuria. Weight loss. Weight loss also, and by the way, this triad of symptoms, polyuria, polydipsia, feeling thirsty, you may find in both diabetes type 1, diabetes type 2. But now we are talking about acute presentation, which is common for diabetes type 1. And that's why in this case, we may find another sign, very important sign. This is weight loss. Weight loss. Actually, remember I told you that diabetes type 2, this is usually obese persons with overweight, and they rarely experience weight loss in case of diabetes. Vice versa, they suffer from obesity. Weight loss typical for type 1 diabetes. Why it's happened? Why it's happened? Remember again about mechanism of diabetes. What for we need insulin? We need insulin to let insulin-dependent tissues to consume glucose. Without insulin, our muscle cells, other cells can't eat glucose. And what happened then? Okay, in patients with diabetes, we have a lot of sugar in blood, but this sugar can't enter cells, And in this case, cells experience what? Starvation. They need energy. They need to eat something, but they can't eat glucose. Because without insulin, glucose can't enter the cells, can't enter cells. What to do in this case? What to eat? Cells need energy. But fortunately, our cells, like muscle cells, they can eat other stuff. For example, they can eat fat. They can eat fat. They can eat proteins, consume fat, consume proteins. As a result, in the body of patients with diabetes, they have accelerated breakdown of fat, accelerated breakdown of muscles, and these fat muscles give proteins used to feed cells, instead of glucose. And actually, due to this fact, patients start losing weight. Again, patients eat normally, but these foods, mostly carbohydrates, can be used by cells without insulin. As a result, patients start using only fat, only proteins, and fat and proteins he eat normally don't enough. Actually, as a result, patients start losing weight. Again, this is typical for type 1 diabetes. What else may happen in case of acute presentation? Ketoacidosis may be the presenting feature if these early symptoms are not recognized and treated in type 1 diabetes patients. Again, ketoacidosis, this is extremely dangerous complication of diabetes, mostly diabetes type 1, and actually this is cause of death because ketoacidosis leads to development of ketoacidotic coma, and without treatment it leads to patient death. And before invention of insulin, all people with type 1 diabetes, they just died soon without treatment. What is ketoacidosis? Why it happens? Again, remember biochemistry. We know already that patients with diabetes, especially type 1, they have intensive breakdown of fat to use it as energy source. During this breakdown of fat, we have formation of so-called ketone bodies. This is acetone, бета-оксимасляная кислота acid, ацетоуксусная кислота, ацетоуксус acid. And this is normal products. They may be found in your blood, in my blood. And then again, remember biochemistry. All these substances utilized in so-called Krebs cycle, or cycle of 3 carbon acids, Krebs cycle. Then, as a result, we have energy, ATF, ADF, ATF, then used for energy to provide sufficient amount of energy for all our processes. But in case of diabetes, what's the problem with this mechanism? That again, Krebs cycle, this is enzymes, and these enzymes, they have some limits. They can utilize only some definite amount of ketone bodies. But in case of diabetes type 1, breakdown of fats and production of ketone bodies exceed actually possibility of Krebs cycle to utilize these ketone bodies. It means we have accumulation of ketone bodies in patient's blood. Ketone bodies, this is acids, and that's why we have development of so-called ketoacidosis. Acidosis is extremely dangerous, You know that actually all our enzymes processes need some level of acid, of pH, because if pH decrease or increase, enzymes can't work normally. As a result, ketoacidosis may cause deterioration of all enzyme processes in our body and finally may cause patient death. And again, patients with diabetes, especially type 1, mostly they may die from ketoacidosis. And ketoacidosis and ketoacidotic coma may be the first presentation if patients don't actually pay attention to polyuria, polydipsia, he don't pay attention to weight loss, development of diabetes lead to formation of diabetic coma, and patient admitted to hospital already in coma. And that's why all kinds of coma, if you have patient with coma, don't forget to check his sugar levels, because it may be diabetic coma with high sugar levels. In case of subacute presentation, this is typical for type 2 diabetes. You know, if you ask patients with type 1 diabetes about beginning of the disease, onset of the disease, patients in most of cases, they can tell you when he became ill. Even he can tell you date, because all symptoms were so obvious that it was understandable and patient can realize when he became ill. If we talk about type 2 diabetes, patient never tell you when he became ill. He doesn't know, because all symptoms are very insidious, and clinical onset of subacute presentation may be over several months or years. This is particularly in older patients with type 2 diabetes. Again, thirst, polyuria, weight loss, usual features. But again, in type 2 diabetes, in many cases, we don't see weight loss. Because again, what's the difference? In type 1, we have absolute deficiency of insulin, no insulin. That's why all exchange process is absolutely damaged. In type 2 diabetes, we have insulin, and insulin present in blood, and insulin don't let severe processes like ketoacidosis to develop. In type 2 diabetes, we rarely see ketoacidosis. That's why, yes, patient has thirst. Yes, patient has polyuria. But weight loss, no, usually we don't see. Patients still overweight, patients still obese. What else? What other symptoms may be? Lack of energy. You know, again, we need glucose for energy, to produce energy. And yes, patients with type 2 diabetes, they can use fats, proteins to produce energy, some amount of glucose, because again, insulin present and some amount of glucose enters cells in case of type 2 diabetes. But nevertheless, not enough energy. And that's why patients start feeling some weakness, tiredness, lack of energy, visual blurring. No, it may be glucose-induced changes in refraction of eyes. It may be sometimes, you know, some infection processes, because again, we need energy to fight with infections too. And in case of lack of energy, we may find some inflammatory processes, And where this inflammation process is typically presented? Skin. As a result, we may find, for example, furunculus, carbunculus. This is purative or abscess formations in the skin, And all surgeons, they know if they see patients with abscess or with furunculus, carbunculus, no, check his blood, his sugar levels. Sometimes such signs as itching may happen, especially in the site of sex organs, especially in women's. Why? Because again, sugar excreted with urine and irritate tissues, because sugar is in high concentration, this is irritatory agent. Yeah? And again, itching in sex organs also may be a sign of diabetes. Then what may happen? Big amount of sugar, bacteria or candidas, like this sugar. That's why they start growing, producing some inflammatory processes. And we may find, again, candidosis, for example, bronchitis, valvulitis, and again, gynecologists or andrologists, they know about this fact. And in case of severe candidosis, they also send patients to check sugar levels, And again, as all these signs are not so advanced, you see no pain, no severe pain, no something terrible happened. And that's why people believe that, no, this is something else, this is not diabetes, and don't visit doctor for a long time, even for years. Again, diabetes type 1 may kill patients soon due to ketoacidotic coma. But in patients with type 2 diabetes, I told you, no ketoacidosis, no coma. Why in this case we believe this disease is very dangerous? Because actually diabetes dangerous due to its severe complications. Which severe complications may be? No, we'll discuss this a little bit later, but typically, diabetes damage vessels. Where we have sugar in vessels. As a result, we have damage of vessels due to diabetes. And as we have vessels everywhere, we may find damage of all organs. But mostly, we have damage of 3 organs. This is brain, this is heart, and this is kidneys. Brain, heart, kidneys, this is typical targets for diabetes. Yeah? And also big arteries, which may cause, for example, development of peripheral gangrene. Yeah? How to diagnose diabetes? How to diagnose diabetes? Diagnostic values for diabetes. No, again, remember definition. Remember definition. Diabetes, this is chronic hyperglycemia. That's why, on one hand, it's very easy to detect diabetes. Just measure sugar levels. Measure sugar levels. Remember numbers. In symptomatic patients, single elevated plasma glucose more than 11 millimoles per liter measured by a reliable method indicates diabetes. So, few ideas. We measure sugar in blood. We measure sugar in blood. We can do this measurement in different time. First approach, known as random glucose. What is random glucose? You measure glucose whenever you want. Morning, evening, before meals, after meals. So it doesn't matter. And again, in healthy person, sugar levels, whatever you eat, never exceed 11 millimoles per liter. So if you have patient with some symptoms of diabetes, for example, feeling thirsty, polyuria, polydipsia, you measure his glucose right during his visit to your office, and you find that his sugar levels more than 11 millimoles per liter. Okay, you may say this is diabetes. No other choice. In other cases, in most of cases, usually we measure glucose early in the morning, and this early in the morning measurement known as fasting glucose, the fasting glucose. So fasting after, because at night patients usually don't eat, that's why we talk about fasting glucose. And you know that you studied biochemistry, physiology, you know that normal sugar levels should be 3.3, 5.5 millimoles per liter. The normal sugar levels 3.3, 5.5 millimoles per liter. If sugar levels, fasting glucose more than 6.1 millimoles per liter, more than 6.1 millimoles per liter, no, you may say that this is diabetes mellitus. Or two random values more than 11.1 millimoles per liter in venous plasma. Again, we talk about asymptomatic or mildly symptomatic patients. Now, again, if you have patients with actually severe ketoacidosis or even in coma, you measure his blood level, sugar level, and find numbers some 30, 40 millimoles per liter. Of course, you shouldn't wait next measurement. It's obvious. But if you see patient with absence of symptoms, it's also possible, or without advanced symptoms. Actually, in this case, you ask your patient, please go to laboratory and measure sugar level at least twice in the morning. And if two fasting readings more than 6.1, no, this is diabetes. Or if two random values more than 11 millimoles per liter, this is diabetes. Again, if you have patient with all signs of diabetes and one reading more than 11, okay, this is diabetes. If no signs, no, everything may happen. Something wrong maybe with the laboratory, something wrong maybe with patient. That's why it's better to repeat this measurement, because diabetes is a serious diagnosis. No, actually, so remember these two numbers. Fasting glucose more than 6.1 diabetes, random glucose more than 11.1 millimoles per liter. This is also diabetes. No, glucose tolerance test is only needed for borderline cases. So what does it mean, glucose tolerance test? Okay, you have patients. His sugar levels, one reading more than 6.1 millimoles per liter, 7 or 7 millimoles per liter. Another day, his glucose levels 5.9, is it diabetes or not? No, you want to prove that this is diabetes. In this case, we should perform so-called glucose tolerance test. Idea of this test is very simple. Let's give patient a lot of glucose and see what happens with his sugar levels. That's why patient visit laboratory. They measure his fasting glucose, and you see that fasting glucose normally should be less than 5.5 millimoles per liter. And then you give your patient glucose. No, they propose 100 grams of glucose, 100 grams of glucose. Just dilute this in glass of hot water and patient drink it. No, another approach, 1 gram of glucose per 1 kilo of weight, because no 100 grams for 50 kilos patient and for 150 kilos patient is something different. That's why sometimes they propose to give 1 gram of glucose per 1 kilo. No, this is not a big difference. And what's then? You ask your patient to measure his glucose level after 2 hours. The glucose level after 2 hours. What happened? Of course, it's a lot of glucose. It's a lot of glucose. 100 grams of glucose, it's a lot, but I told you that actually 100 grams of glucose you can find in 1 liter of Coca-Cola. And if you drink 1 liter of Coca-Cola, you perform glucose tolerance test, by the way. So, what happened after 2 hours? In healthy person, sugar level should be less than 7.8. You see, it's not 5.5 because after meals you eat, our patient ate a lot of glucose. Of course, body needs some time to utilize all this glucose. It can't be done in seconds. But nevertheless, in healthy person, sugar levels less than 7.8 millimoles per liter. If sugar level more than 11.1, the same number, you know this number already, this is diabetes. And again, fasting glucose less than 5.5, this is normal. More than 6.1, this is diabetes. But what to do if numbers something between? For example, let me say 10. This is not normal, but this is still not diabetes. In this case, we tell that this is impaired glucose tolerance. Impaired glucose tolerance. This is not diagnosis of diabetes, but this is already not normal. And actually, what to do with patients with impaired glucose tolerance? You know that 2% of population will be found to have unsuspected diabetes on an oral glucose tolerance test. It means that patients feel nothing. He has no signs. If you examine 100 people, you'll find 2 of them will suffer from impaired glucose tolerance. 5% or more will fall into an intermediate category, rated as impaired glucose tolerance, and this is not a clinical entirety, but a risk factor for future diabetes and cardiovascular disease. What we're talking about? Impaired glucose tolerance, actually, again, try to repeat this idea. If you catch 100 people on the street and ask them to do glucose tolerance test, you will find that 2% of them suffer from diabetes due to numbers. His sugar levels will be more than 11.1 random or more than actually 6.1 fasting. And 5% or more will be with impaired glucose tolerance. So their sugar levels will be higher than normal, but still not diabetic. And if we have a person with impaired glucose tolerance, you shouldn't prescribe treatment. You shouldn't treat this patient because it's not diabetes, it's not disease. But this patient in the risk group, he has high chance to produce diabetes in future. That's why you should follow up these persons with impaired glucose tolerance, because they have high chance to start suffering from diabetes. Maybe not. Maybe he will live all his life with this impaired glucose tolerance, but chance to suffer from diabetes higher than in general population. So what else we measure? What other tests we do to detect diabetes? So one of such tests known as glycosylized hemoglobin or HbA1c, glycosylized hemoglobin. So what is it? You know that glucose, small molecule, this molecule can attach to other molecules, to big molecules. For example, to proteins, glucose like proteins, and can attach to proteins. And this attachment may be irreversible, may be irreversible. In this case, we talk about glycosylation. So we have some bond between the glucose molecule and actually proteins molecule. Which proteins we can find in blood? No, number one protein, this is hemoglobin. Now we have 160 grams per liter of hemoglobin. Hemoglobin, this is protein. And that's why glucose can attach to hemoglobin, and in this case, we talk that this is glycosylized hemoglobin. Glycosylized hemoglobin. And normally, in healthy person, we have about 4 to 8% of hemoglobin, which is glycosylized, No, okay, this is normal. But by the way, and if glucose attached to hemoglobin, they travel together till this hemoglobin will be broke down. Now you know that erythrocyte live 4 months, and hemoglobin also live 4 months, and after that it's destroyed. Okay, what do you think? If we have patients with diabetes, what happens with these glycosylized hemoglobin levels? Now, if we have more glucose, of course, we have more glycosylized hemoglobin. As a result, this percentage of glycosylized hemoglobin will be higher than normal. Let me say 10, 11, 12. Now it's clear. More glucose, more glycosylized hemoglobin. More glycosylized hemoglobin. And we can check and detect that this patient has more glycosylized hemoglobin than normal. But you may ask, and what for we do this? Now we can check just pure glucose. It's much more easy to do, very simple test. Let's check glucose. What for we should detect glycosylized hemoglobin? You know that glycosylized hemoglobin give us ideas about some average blood glucose concentration over the life of the hemoglobin molecule. Now again, approximately 6 weeks. So what does it mean? Now just imagine you have patients with diabetes, let me say type 2. You told your patients, don't eat sweet stuff, don't eat candies. Your sugar levels will be higher than normal. And you ask your patient, please visit me in 3 months. Patient came back home, forget about your advices, ate everything, candies, sugar, and his sugar levels were very high. Then he remembered, okay, I need to visit doctor. Doctor told me don't eat sweets. And he stopped eating sweets. And for example, 2 or 3 weeks, no, at least a few weeks, don't eat candies. What happened with his sugar levels? Decrease. He visits your office, you measure his sugar levels good. But if you check glycosylized hemoglobin levels, you will find that glycosylized higher than normal. Why? Because few weeks before, patients actually violate your recommendations and eat a lot of candies. That's why actually sugar level in blood, very changeable. Patient eat sugar, rise, don't eat, drops. But in patient, what glycosylized hemoglobin give us some average, because if glycosylized hemoglobin is normal, it means that previous few months everything was normal with carbohydrates exchange. And again, if it feels higher than normal, something was wrong. That's why again, glycosylized hemoglobin give us ideas about what happened in the past. Okay, let's start again about complications of diabetes. I told you that number one target for diabetes, this is vessels. This is vessels. We have big vessels and we have small vessels. And diabetes may cause microvascular complications, big vessels, macros, yeah? And may cause microvascular complications, small vessels. No, big vessels, this is arteries. Small vessels, this is capillaries and arterioles. Capillaries and arterioles. What happened with these vessels? Macrovascular complications, big vessels. So diabetes accelerates, this is risk factor in the development of atherosclerosis. So what does it mean? Now you know that atherosclerotic process you may find in all people, especially with aging. Yeah? Atherosclerosis you may find in people after their 30s, 40s, 60s, and with aging, number of atherosclerotic damaged vessels increase. But diabetes accelerate this process in many times. Why it's happened? No, different theories. First of all, remember I told you that in patients with diabetes, they don't have enough energy. That's why it causes breakdown of lipids. And in blood of patients with diabetes, often we can find actually lipids in high amounts, hypercholesterolemia. And hypercholesterolemia, this is main risk factor for development of atherosclerosis. And also, sugar can damage vessels, and damaging of vessels also cause progression of atherosclerotic process. What we see clinically, how it's presented, because atherosclerosis causes what? Plugging of vessels, the plaques, thrombosis. What are results of such thrombosis? Where such thrombosis may happen? First of all, two main organs, brain and heart. Thrombosis of brain vessels cause stroke. Thrombosis of cardiac vessels, the coronary arteries, cause myocardial infarction. And what we can see, stroke is twice as likely in patients with diabetes compared with people with the same age without diabetes. So 2 times. Myocardial infarction 3-5 times is likely. And women with diabetes lost their premenopausal protection from coronary artery disease. So what we're talking about, patients with diabetes 2 times more often suffer from stroke and 3 to 5 times more often than from myocardial infarction. You know that these cardiovascular events, stroke and myocardial infarction, main 2 killers. And that's why people with diabetes type 2 die. They don't have coma diabetes, but they may die from stroke or from myocardial infarction. And what else may happen? This is damage of big vessels of limbs, mostly of lower limbs of legs. If we have plugging, the catastrophe, thrombosis of low extremities, it cause what? Gangrene, because without blood, no blood circulation, tissues died without actually oxygen, without nutrition. So as a result, we see gangrene. And amputation of foot for gangrene 50 times as likely. So mostly all cases of gangrene and amputation, this is a result of actually, unfortunately, of diabetes. No, this is gangrene. This is black stuff. This is dead tissues. This is dead tissues. Why no blood supply? All vessels completely blocked by atherosclerosis, and what to do in this case? In most of, and you know the problem. This is not one actually place. If it will be one place, okay, let's do some operation, surgery, balloon angioplasty, insert stent. Unfortunately, this is total damage of vessels, and in this case, surgeons, they what to do? Amputation. Because if you don't do amputation, patient die from gangrene, from severe intoxication. Small vessels, microvascular complications. Small blood vessels throughout the body affected, but disease process is of particular degree in 3 sites. So microvascular complications like retina, eyes, the renal glomerulus, kidneys, and nerve sheath. So this is actually vessels which provide blood supply for nerves, the blood supply for nerves. And this is 3 sites, 3 targets for microvascular complications. Why it's happened? No, if we talk about pathogenesis mechanism very briefly, you know, again, remember I told you about glycosylation, the glycosylation when we have glycosylized hemoglobin. But this glucose molecule may attach not only to hemoglobin, it may attach to all proteins. And you know that all our body is proteins, our cells is proteins. And if actually glucose molecule attached to proteins, you know that function of proteins depends on their shape. If proteins has a lot of glucose molecules attached, it may change somehow change the shape of proteins. Change of shape, change of function. Of course, in most of cases, this is actually malfunctioning. Rather, it may improve somehow functioning of proteins. Where we have proteins in vessels, that's why if we have damage of proteins, it may cause what? Membranes becomes not permeable. We have leakage of proteins into vessels wall. This process known as arteriolosclerosis. The proteins deposited in the wall of vessels. As a result, we have actually vessels start squeezing. Actually, they don't let normally actually blood to pass through. What else may happen, unfortunately? You know that when proteins change their shape, our immune system may realize this is wrong protein. This is maybe enemy protein. Let's kill it. Let's destroy it and start inflammatory process. As a result, we have inflammatory process in vessels, which finally lead to what? To damage of vessels, to thrombosis. Finally, we have vessels which are damaged, thrombotic, and that's why no blood supply. And if we talk about such organs as eyes, kidneys, without blood supply, they can't work proper way. We have clinical presentation of this microangiopathy. By the way, we talk about diabetes type 1, type 2. Type 1, young people, type 2, elder people. And that's why, remember please, that macrovascular complications, atherosclerosis, of course, more often we can find in elder people, because atherosclerosis, this is age process. Microvascular may be found both, but mostly in young people with diabetes type 1. Diabetes type 1. Okay. So which actually what happened with eyes? You know that retina, this is vascular layer of eyes. They provide blood supply for our eyes. We need blood supply to see something because we have receptors, optic receptors, and this receptor, this is cells, they need food for normal working. And what happens if we have damage of vessels, we have damage of these sensors, which actually can catch actually light. No result, we have problems with vision. We have problems with vision. And this is known as retinopathy. Retinopathy. So, you know, I will show a picture. This is normal, actually, bottom of eyes or ocular fundus. You can see this picture if you use special device, ophthalmoscope. You can use this device. We can use special device, ophthalmoscope. No, this is usually used by ophthalmologists. Now you can see the same, but for patient with diabetes. What happened? What I told you, that vessels affected by diabetes, microvasculopathy, becomes very fragile. They easily break down. They easily give leakage. You see, this is this red spots. This is leakage of blood. Leakage of blood. These clouds, claudication. This is leakage of plasma. Leakage of blood. Leakage of plasma. You see dots. These red dots. And we have one problem. You know that actually our eyes constructed wrong way. What I mean wrong way? If you construct some actually optic sensor, what you should do? First, put sensors, and then you put some wires to feed these sensors. In our eyes, we have opposite. First, we have retina, and below retina, we have receptors. That's why if something happened with retina, for example, blood leakage, this blood leakage don't let light to reach our senses. That's why all these actually leakage of blood, all these bleedings should cause blurred vision. You know, that's very interesting that in many cases patients don't see this. Patients don't see some black spots. Why? Because the main organ of vision is not eyes, this is brain. Our brain, like computer, can actually somehow separate these actually signs without vision, make some extrapolations, calculations, and patients see normally. Patients start understanding that something wrong with his vision, something wrong with his vision. Vision is not so sharp as it was. What else may happen? You see, what can you see? A lot of vessels, a lot of vessels. This is so-called proliferative retinopathy. What's happened? If we have blocked normal vessels, tissues experience ischemia. Tissues send signals, we're hungry, give us blood. How to give more blood? Well, let's grow new vessels. And you see, we have a lot of new vessels which are growing. No, sounds great. But just imagine, if you see so huge amount of vessels, how light can pass through. Light can't pass through this huge amount of vessels. And again, vision decrease. And even more serious complication may happen. You see, what is this? This is collagen. This is scar in eyes, in eyeballs. Where is scar? Where is this scar? Now just imagine eyeball, the eyeball. The problem when vascularization, when this huge amount of vessels start growing, they start growing not only in retina, they start growing into vitro, They start growing inside eyeball. And inside eyeball, these new vessels also very big. They also easily break down and easily produce leakages. And just imagine, now we have hemorrhages, not only in the retina, we have hemorrhages inside vitro, in eyeballs. Of course, it's again, don't let light to pass through. But more serious complication may happen. Okay, we have some actually hemorrhage inside vitro. Hemorrhage never stay forever. Instead of hemorrhage, usually we have formation of collagen, of scar. And this is scar instead of hemorrhage, which was previously. But you know that scar shrink in all times. Scar usually in the volume, if you talk about volume, less than previous tissues, less than previous damage. That's why scar usually shrink tissues. Now it may be seen, especially if you have some scar on the face. Why it's bad? Just imagine, we have retina. From retina, we have vessels which grow inside vitrum, and we have hemorrhage. When scar squeezing, shrinking, vessels which attach to the site of scarring start doing what? Start pulling retina, into vitro. And this may cause what? Detachment. Now we have air, bottom of eyes, and we may have detachment of retina from the bottom of eyes. If we have detachment, it means that complete stop of feeding of sensors, and without feeding, cells died. This detachment may cause complete loss of vision and may cause absolute blindness. That's why, again, in the whole world, actually, diabetes, this is #1 cause of actually blindness. just because we have a lot number of patients with diabetes. This is interesting picture. You see these white spots, what is it? It looks like someone shoot some bullets that damaged retina, and it's really so, but it's not bullets, this is laser beam. So ophthalmologists, they use very powerful laser, you know, laser, shoot actually bottom of eyes. What for? They cause damage, all these sides damaged. But you know, the idea is following. They shoot with laser, and in this side, we have damage, and then instead of damage, we say we have scarring process. What for? This is some kind of welding, you know, welding. When we need to attach to actually steel, I don't know, plates, you use welding, the procedure. Welding procedure, the same welding procedure happens here, because we attach retina to the bottom of eyes. This don't let retina to detach. Yes, patient lose some percent of vision, but he avoid complete blindness, which may happen in case of detachment of retina. Kidneys, diabetic kidneys. Remember what I told you about vessels in eyes. Absolutely the same may happen with vessels in kidneys. Where we have vessels in kidneys? In glomerulus. That's why we have glomerular damage. Ischemia resulting from hypertrophy of efferent arterioles. So again, if to say briefly, we have damaged arterioles in glomerulus thrombotic, damaged, but without glomerulus, we can't filtrate urine. And that's why it causes process which is known glomerulosclerosis. Glomerulosclerosis leads to renal failure. And you know that especially young people with diabetes, if they avoid death from ketoacidotic coma, even if they use insulin, in some of cases, unfortunately, they have glomerulosclerosis, they have renal failure, and they may die from renal failure. No, infection also may accompany it because of low immunity and damage of kidneys. Clinically, first what we can find, this is microalbuminuria. First we can find just actually some amount of proteins in urine due to damage of glomerular filter. Then we have macrohematuria, then we have glomerulosclerosis, or sometimes known as Kimmel-Still-Wilson lesion, Kimmel-Still-Wilson glomerulosclerosis. No, but again, remember that finally it may cause renal failure and patient death. Next target for diabetes, this is nerve system. We have development of diabetic neuropathy, neuropathy. In most of cases, we have so-called peripheral neuropathy. The peripheral nerves, tissues, affected in a number of ways. We have vascular hypothesis that damage of nerves happen due to damage of vasa nervorum. Remember I told you that we have big nerves supplied by blood through some vessels, and we have damage of vessels. Of course, without good blood supply, nerves can't survive, and we have damage of nerves. It may be some metabolic cause, some metabolic changes in nerves also may cause damage of these nerves. For example, some accumulation of sorbitol, fructose in Schwann cells. What is Schwann cells? You know that nerves is like a wires. We have wires everywhere. We have wires for electricity everywhere. And how these wires constructed? In wires we have some steel or cuprum inside, and we have isolator. Isolator don't let electricity to go out. And nerves is this huge number of such wires. and isolator. This is so-called Schwann cells. Schwann cells, they serve as isolator of wires. In case of diabetes, due to metabolic processes, we have damage of such Schwann cells, we have damage of isolators. What happens if you have few wires, or if you have few actually wires with damage isolation? You have shortcut, and the result, impulses can't conduct proper way, nerves can't work proper way. We have damage of structure and function of nerves. Diabetic neuropathy usually presented clinically as symmetrical sensory polyneuropathy. Symmetrical sensory polyneuropathy. So what does it mean? Patient lose his feeling of what? Of temperature, tactile pressing. If you press, you feel how you press. Patient lost such feeling of pressing. Patient lost feeling of temperature. That's why patient can catch something very hot but don't feel it and have burns. Cold or temperature, actually sensitivity also may be damaged. So patient lose all sensations, all feelings, sensitivity decrease. Sometimes maybe acute painful nerve. Sometimes patient feel pain in fingers, in legs. This is also not due to damage of tissues, but due to damage of nerves. Damage of nerves. Sometimes we have damage symmetrical. Why symmetrical? Because it's usually symmetrical. The two hands, and they tell this is damage like a glass. The two gloves, two hands symmetrically damaged. Or feet like socks, because two legs symmetrically damaged. It may be damage of big nerves, mononeuropathy. For example, some cranial nerve lesions, and remember anatomy, function of cranial nerves, and they may be somehow damaged. Somehow damaged. So, and third, what may happen in diabetes, this is actually different infections. Patients with diabetes more often suffer from tuberculosis, pneumonia, pyelonephritis. You know now this story with COVID. Why some people survived, some people died. Now we see that the most dangerous risk factor in case of COVID infection, this is diabetes. And for patients with diabetes who suffer from COVID infection, chance to die few times higher compared with person without diabetes. The same history, the same story. Low immunity, patient's body can't fight against this infection and patient died. That's why again patient with diabetes often suffer from different infections, That's why totally patients with diabetes live less, they have less life expectancy compared with people without diabetes. Okay, that's all for today. If you have questions, please write your questions in the chat. In the chat. You shouldn't write your presence in the chat. In the chat, you can write only your questions. Okay. If you have some questions, please write. Again, you should not write your names in the chat for registrations. Now registration is done automatically. If you have questions, please write these questions in the chat. Okay, if no questions, see you next lecture, 26th of November. 26th of November. Okay, in this case, bye. See you next lecture.
Thank you for having